There's been so much progress in our new drugs, new strategies. As a result, phase 2 randomized trials looking at survival as a primary endpoint is simply not rational any longer. And the reason for that is, if you conduct a trial, you have regimen A versus regimen B, and patient progresses, goes off the trial, that would be progression-free survival as an endpoint or disease-free survival as an endpoint, which is what the trial endpoints have to be now. But if you looked at overall survival as an endpoint, that would assume that what happens to a patient after they go on that trial is going to be the same, or pretty much the same for patients on either arm of the trial. And that's a completely irrational endpoint. And a comment, because we are not now talking about patients who might live after they finish a trial 1 or 2 or 3 months. We have patients who are living a year, 2 years, 3 years, and longer after they finish a trial, and therefore holding that drug or that combination that the patient might have received 2, 3+ years ago hostage, and that's the term I will use, hostage to a survival endpoint when all of the things that might have happened to the patient population in the interim is not controlled in the trial, simply makes no sense. And the risk is that we will actually discard potentially extremely valuable drugs because of this, quite frankly, irrational endpoint. Now, stating that doesn't mean that an individual drug or strategy can't improve overall survival. That's not what I'm saying. Because if obviously we had this wonderful new drug or strategy, whatever it may be, a new immunotherapy agents, and we did a trial and we hit a home run or a grand slam, and in fact the patients on that trial in fact did live substantially longer, that'd be wonderful. That's not the point. The point is we could see enormously positive outcome. Very valuable strategy, independent of the question or the issue of did that drug in that trial improve overall survival? That's the point.